In Rescue TEE Part 1, we introduced the T-Time Rescue TEE protocol. Now with this Part 2 episode, how do we actually use Rescue TEE clinically to diagnose and manage RV failure, cardiac tamponade, acute PE, hypovolemia, and more? Sit tight, we'll cover these and so much more in this episode of T-Time. Welcome to Tea Time. I'm Dr. Andreas Plakis, and in this episode 16, we're going to be talking about Rescue TEE, Everything You Need to Know, Part 2. The clinical question we're going over is how can Rescue TEE identify shock states and improve patient care in emergent settings? We have been going over Rescue TEE in a 3-part series, and we already covered last episode, Tea Time Rescue TEE Protocol. Part 2, we're going over common diagnoses and shock states that you will see in Rescue TEE exams. If you didn't catch this last episode, we do have a free resource available for you as well. This T-Time Rescue TEE protocol. This is an incredibly high-yield 2-page summary of all that we're talking about with Rescue TEE that you can use clinically. If you're on Apple or Spotify, leave us a review. If you're on YouTube, hit the like button. Then in the comments section, tell us one thing you like about the show and leave us your email, and we will get this document to you so you can use it electronically. You can print it out, laminate it, keep it on your TEE machines for emergencies, but this is just for you. Let's briefly review what we went over last episode, but in step 1 of the T-Time Rescue TEE evaluation, you're going to perform 3 basic views initially: the mid-esophageal 4-chamber view, mid-esophageal long-axis view, and the transgastric mid-papillary short-axis view. In each one of these views, you're going to look in the heart for volume assessment and clot. Look at the heart for global and regional LV function, valvular function, and then look around the heart for the presence of fluid or compression. Based on this evaluation, you'll hopefully determine if there's a problem with preload, contractility, or afterload that could be causing hypotension or cardiac arrest. The next step, step 2 of this T-Time Rescue TEE protocol, is to take the information gained in step 1 and to differentiate that shock component and diagnose pathology further. We'll either narrow into this preload, contractility, or afterload and try and diagnose the pathology itself. Then finally, in step 3, we'll perform a complete basic perioperative TEE exam to make sure we're not missing other things and do it in a systematic way. While some of those steps may seem simple, there are a variety of causes of perioperative hypotension, hypoxemia, or cardiac arrest. You can see the list here that they are still divided into that PCAR acronym: preload, contractility, afterload, rate, rhythm. Before we jump into specific diagnoses, let's go over how to actually calculate cardiac output using echocardiography. This is an important skill to have, as being able to perform this will allow differentiation between different types of diagnoses. The equation for cardiac output is heart rate times stroke volume. Anytime you measure a volume, the equation is area times distance. In this instance, the area will be the cross-sectional area at the LVOT, and the distance will be the velocity time integral, which is also called the stroke distance, and it's measured in centimeters. To measure the cross-sectional area at the LVOT, we'll take the diameter at the LVOT and plug it into the formula of pi r squared. And because you're measuring diameter, you'll do pi times diameter divided by 2 squared at that mid-esophageal aortic valve long-axis view. Then when you measure the VTI, you'll get a pulse wave Doppler of a deep transgastric long-axis view. Trace that waveform and it will give you the LVOT VTI. When you plug those values into this stroke volume formula, it will give you an accurate stroke volume, assuming you measure them correctly, and then multiplying the stroke volume by heart rate will give you a cardiac output. An alternative way to measure cardiac output is using 3D quantification with full volume to calculate it with post-processing functions. Let's start by focusing on diagnoses that are associated with abnormal preload, where we fail to get blood adequately filling the left ventricle. The first cause of abnormal left ventricular preload is hypovolemia. This is defined as decreased intravascular volume. Hypovolemia leads to reduced cardiac filling, which causes reduced ejected blood from the heart. Causes of this are blood loss, non-blood fluid loss, so severe dehydration, or third spacing of fluid. Non-echocardiographic clinical signs you may see are significant pulse pressure variation, bleeding source in a perioperative setting, changes to your arterial line waveform where you may have decreased area under the curve of that waveform, and you'll see a reduction in your CVP or PA pressures if you're monitoring them. The treatment for this condition is replacing the fluid or blood losses that the patient has. The most common views I use to assess for hypovolemia are the mid-esophageal four-chamber view and the transgastric short axis view. Some of the features you may see are that the LV is empty in systole and very small in diastole. Crude marker for this is that the LV end diastolic diameter is less than 3.5 centimeters. Basically, your left ventricle starts small and gets even smaller. If you measure cardiac output, you will have a low cardiac output, even though your ejection fraction is frequently high and hyperdynamic. If you look at the RV size, this will be underfilled as well, and then you can assess for markers of fluid responsiveness and see a clinical picture that indicates a patient would benefit from more volume administration. What are some of the ways that we can assess fluid responsiveness in the operating room setting with echocardiography? Would additional volume infusion really improve my hemodynamics? Two of the ways you can do it in the operating room setting are assessing LVOT VTI variability, and the measure here is greater than 12%. In this deep transgastric long axis view, you will see this changing waveform that would indicate significant variability in your LVOT VTI. Another way to do it is by assessing SVC collapsibility. If there's an SVC collapsibility greater than 36%, this would tend to indicate that the patient would be fluid responsive. This can be measured from a mid-esophageal bicable view or a mid-esophageal ascending aortic short axis view. I tend to like this bicable view where I can put M mode through the SVC and actually measure the degree of collapsibility with that. Some important features when you do these are to make sure that the patient is ventilated without spontaneous efforts, to see tidal volumes greater than or equal to 8 cc's per kilogram, make sure the patient doesn't have any arrhythmias like atrial fibrillation, and that the patient has normal chest wall compliance where they have a closed thorax and no flail chest. You can reassess these measures as well after a fluid bolus to see if there has been success. If you have a patient who has a clinical picture of hypovolemia, you can perform what's informally known as a TEE fast exam. This is a system I perform where I could try to find the source of bleeding. I'll start by looking in the right chest for a significant hemothorax, pleural effusion. I'll roll over to the left chest where I should see the aorta and notice any additional effusions. Then I'll push into the stomach and look at the right side where I look around the liver and I can see my IVC as well on that side. And then I roll left to look at my left upper quadrant to see if I see any blood around the spleen on that side. The next diagnoses you'll be looking to evaluate for in the preload section is for IVC compression. It could be due to abdominal compartment syndrome, surgical compression, or from a thrombus or mass that's present. If there's any cause of IVC compression, it impairs blood return to the heart. And with this reduced cardiac filling comes reduced cardiac output. You may see abdominal distension if it's from abdominal compartment syndrome, reduced urine output, increased ventilator, peak inspiratory pressures. And the treatment really depends on the cause, but it could be to minimize this compression or surgery for abdominal decompression for abdominal compartment syndrome. To evaluate for this with echo, I'll look at my transgastric IVC view. Some of the features you may see are a very narrowed and collapsed IVC. Your RV and LV should be underfilled because they're not getting adequate preload. You'll want to rule out the presence of a thrombus or mass and also look for the presence of blood or fluid seen in the abdomen as well. Here's a case of a patient who had a compressed and narrowed IVC on the left, and then after an XLAP was performed and blood was evacuated and that pressure was relieved, you see a very normal looking IVC after the fact. Also, in another patient, we see significant blood around the liver, and because this abdominal bleeding was so prominent, it was also causing abdominal compartment syndrome in this patient where you see a very collapsed IVC. The next diagnosis we'll look at is cardiac tamponade, which could cause inadequate LV preload. This is defined as pericardial fluid or blood that compresses the heart chambers. Increased pericardial fluid leads to cardiac chamber compression, and impaired filling leads to impaired cardiac output. It's associated with trauma, post-heart surgery or cath lab, renal failure, cancer, or autoimmune disease as well. Clinical signs you may see are jugular venous distension, pulsus paradoxus, electrical alternans, and then eventual equalization of CVP, pulmonary artery diastolic pressure, and pulmonary capillary wedge pressure. The treatment really depends on the clinical circumstance and the urgency of procedure, but it could be a pericardial drain, pericardial window, sternotomy to evacuate the fluid, or correction of coags. When I evaluate for tamponade with TEE, I try to use as many views to look at all the chambers of the heart as possible. But some of these would include the mid-esophageal 4-chamber view, 2-chamber view, long axis view, and the transgastric short axis view. Some of the features you may see are obviously fluid or blood in the pericardial space, and this could either be circumferential or it could be a loculated clot. To diagnose tamponade, you need right atrial or left atrial collapse in systole for greater than 1/3 of the cardiac cycle. Or you'll want to see RV or LV collapse in diastole. If there is no chamber collapse whatsoever, that's a greater than 90% negative predictive value for tamponade. And you'll see in this echo clip here, even though there's presence of fluid, you see atrial contraction, but you don't see chamber collapse for greater than 1/3 of systole for that right atrium. So this would not be characteristic of tamponade. You'll also see ventricular interdependence. This is where you have significant respiratory variability, where you could see changes in your tricuspid valve inflow velocity above 60% and your mitral valve inflow E velocity greater than 30%. Finally, characterizing tamponade using echocardiography can be done somewhat based on size, where a small amount, less than 100 mLs of fluid, is an echocardiographic width measured less than 1 centimeter, moderate 100 to 500 mLs would be seen on echo 1 to 2 centimeters, and then large, which is greater than 500 cc's, would be a greater than 2 centimeter echocardiographic measurement. And remember though, the hemodynamic influence of tamponade is based on the rate of growth, not necessarily the size of the effusion. So if there was no baseline effusion and there was rapid growth, that is much more significant than a very large effusion that has been there chronically for quite some time. The next cause of abnormal LV preload is RV failure. This is defined as ineffective RV cardiac output. Inadequate RV function leads to insufficient blood being sent to the LV to be ejected to the body. And also, as that RV dilates and is hypokinetic, it can impinge on LV filling and cause further reduced cardiac output. Causes of this are pressure overload that could be caused by a PE, pulmonary hypertension, or left-sided heart disease, volume overload that could be caused by tricuspid regurgitation, pulmonic insufficiency, shunts, or excessive volume administration, or poor contractility that could be seen in the context of a myocardial infarction or cardiomyopathy. Clinical signs seen are jugular venous distension, increasing CVP with a decreasing PA pressure, ascites, or peripheral edema, or other signs of right heart failure. The clinical treatment is to create a higher heart rate, increase the SVR or systolic blood pressure, inotropes, pulmonary vasodilators, and to ensure the patient is euvolemic, not volume overloaded. To evaluate right heart failure, I look in the mid-esophageal 4-chamber view and then the transgastric short axis view with or without an RV inflow-outflow view. You may see the RV function depressed. The RV is typically dilated with the interventricular septum bulging towards that left ventricle. As that bulging occurs and the RV dilates, it can cause new or worsening tricuspid regurgitation. And also because these are preload deficiencies of the LV, that LV, of course, will be underfilled. The right atrium is often dilated as well. One of the important things to look at here is the interatrial septum. This has been known as the barometer of the ventricles. If you see it bulging from the right atrial side towards the left atrial side, this can be indicative of very high right atrial pressures and be concerning for RV failure as well. The most important first step when we see a patient with abnormal preload is to look at the RV next to differentiate between hypovolemia and RV failure. Anytime a patient has an underfilled left ventricle, the next thing to do is look at the right ventricle. This is easy to miss for beginners, and that's why we always go through all 3 steps of this rescue TEE evaluation, and we don't stop at just one. But both of these left ventricles look underfilled and look pretty similar. You can see on this left image that the right ventricle is not moving well at all, and RV failure is the cause of the underfilled LV. Whereas you can kind of see in this right image that the RV is not dilated and is also underfilled, and hypovolemia would be the cause of this patient's hypotension. Next, let's keep moving down the causes of inadequate LV preload. Let's look at embolism as the cause. This is defined as obstructed pulmonary artery or arteries, where an embolism would travel to the pulmonary artery and obstruct blood flow, causing RV failure and also causing underfilling of that left ventricle. The things that could travel to the pulmonary arteries and obstruct blood flow are clot, which would be a pulmonary embolism, air, cement, or an amniotic fluid embolism. Clinical signs you may see outside of echo are hypoxemia, a significant drop in end-tidal CO2, or you may see a DVT present with leg discoloration. Some of the treatment options available are anticoagulation, thrombolytics, and catheter versus surgical embolectomy. When considering a pulmonary embolism as the cause of the patient's shock, you want to look at a few views: the mid-esophageal four-chamber view and the mid-esophageal ascending aortic short-axis view. You may see clot or material in this main PA or right PA. You can see that in this image here. When looking at the RV, you'll see a dilated failing RV, and you may even see this McConnell sign where you have apical sparing but free wall akinesis. The LV will be underfilled because the RV failure will fail to send blood over to the left side to adequately fill that LV. You'll also want to perform a search for clot. If you don't see it in the pulmonary arteries and you do have high clinical suspicion for it, you want to look in the right ventricle, the right atrium, and even down in the IVC to see if there's any source of thrombus that could have caused a pulmonary embolism. Looking in the common femoral veins for DVT is another important clinical skill to have that can be very easily performed. There are lung causes to low LV preload. The most important of these is a tension pneumothorax. This is defined as air accumulation in the pleural space that leads to increased intrathoracic pressure and subsequent mediastinal shift. This will impair venous return, which leads to decreased cardiac output. The causes of a tension pneumothorax are trauma or positive pressure ventilation. And the clinical signs that you may see are hypoxemia, high vent pressures, and jugular venous distension. The treatment is needle decompression and chest tube placement. What will tension pneumothorax look like on echo? This is one of the few that you cannot definitively diagnose with TEE alone, so it's always got to be in the back of your head as something you're considering, especially if you see an underfilled LV or you're not quite sure what's going on. Some of the views you'll use are a mid-esophageal four-chamber view and then a lung ultrasound exam. The echocardiographic features you may see with TEE are hypovolemia, where you may just think it's a hypovolemic patient. You may see atrial or ventricular chamber compression, as was seen in this patient in this top picture right here, without clear fluid in the pericardium. If you look at the LV and the RV size, these will be underfilled, and the IVC will be dilated. It won't be collapsing at all because the impaired venous return will cause distension of the IVC. Again, you cannot confirm tension pneumothorax with TEE alone. It can create greater clinical suspicion, but you need lung ultrasound or further imaging to confirm tension pneumothorax. So if we're going to do additional imaging, how does it work with lung ultrasound? There are certain findings that rule in the presence of pneumothorax or rule out the presence of pneumothorax. There's a pretty standard exam where there's 3 different points on each side of the chest that you can look with a linear ultrasound probe. Some of the factors that will decrease the likelihood of pneumothorax are the presence of lung sliding, the presence of lung pulse seen here, and the presence of A or B lines as well. All these findings can be present when you see the parietal and visceral pleura up against each other. However, if the lung is dropped because there's a tension pneumothorax, a lot of these signs may be absent. If you use M-mode as well, you may see this sandy beach or seashore sign that's caused by movement of the lung. However, if you do the same thing in the presence of a tension pneumothorax, you may see what's known as a barcode sign, where you don't see movement of the lung below it, and it creates this static appearing image. Also, what's pathognomonic for pneumothorax is this lung point, where you see the lung point coming in and out of the view. This is highly, highly concerning for pneumothorax. Let's move on to the final cause of abnormal LV preload. This is where you have certain valve pathology that prevents blood from getting to the left ventricle adequately. A full valve interrogation is beyond the scope of this episode, but in brief, this is defined as any valvular disorder that negatively influences forward cardiac blood flow. If you have stenotic valves that impede forward flow or regurgitant valves that allow backward flow, all this affects blood from reaching the left ventricle. The etiology for some some of these things in the acute period are endocarditis, myocardial infarction, trauma, procedural complications. Some of the non-echocardiographic clinical signs are the presence of a murmur, right or left heart failure symptoms such as pulmonary edema, jugular venous distension, and peripheral edema. And then the treatment here really is treating the congestive heart failure symptoms and subsequent valvular intervention as well. For the tricuspid valve, you want to look at the mid-esophageal four-chamber view, RV inflow-outflow view, and possible modified bicable view. For the pulmonic valve, you'll look at your RV inflow-outflow view, and you can see it even better sometimes in this upper esophageal aortic arch short-axis view. And then to interrogate the mitral valve, I've gone over extensively in previous episodes. I'll look at this mid-esophageal commissural view, and then the mid-esophageal long-axis view to further interrogate that. I still want us to focus big picture on what it is we're actually looking at, because for rescue TEE, we're not wanting to get caught up in the minutia. We're just wanting to answer the clinical question, can this valve be contributing to severe hypotension or cardiac arrest? So using the eyeball test, we'll ask, does the valve open and close? Opening, is there good excursion of the leaflets? Is there turbulence on the upstream side that could indicate significant stenosis? Closing, is there symmetric coaptation? Is there a significant regurgitant jet? And then look at the associated heart chambers to see if it's chronic or acute. For the tricuspid valve, if you have significant TR, frequently you have right atrial and RV dilation, and tricuspid stenosis would cause right atrial dilation with a normal size RV. For the pulmonic valve, you may see significant RV dilation with pulmonic insufficiency and RV hypertrophy in the presence of pulmonic stenosis. And for the mitral valve, for MR, you may see left atrial and LV dilation, and for mitral stenosis, you'll see left atrial dilation with a normal LV size. The next of the big three categories is looking at contractility. Why is the left ventricle not ejecting blood properly to the organs? This can be divided into global or regional LV dysfunction. So we'll start with global LV dysfunction. This is where you have impaired global contractility, where you have inadequate LV contraction that leads to insufficient delivery of blood to the organs. Causes for this include cardiomyopathy, whether it's ischemic or non-ischemic, or some other cause like Takotsubo's, drug-induced cardiomyopathy, or trauma causing this. You'll frequently see this dilated LV, and after it contracts, you'll still see a dilated LV, just slightly smaller. The non-echocardiographic clinical signs include the potential for pulmonary edema, inspiratory crackles, rising pulmonary artery diastolic pressure, and RV failure. The treatment, if it's a global LV dysfunction, include inotropes, vasodilators, diuretics, and possibly even mechanical circulatory support. Some of the views you can use to assess this are the mid-esophageal four-chamber view, mid-esophageal long-axis view, and the transgastric short-axis view. The features you may see are a large dilated left ventricle. You'll see reduced global LV function. And keep in mind that the LV ejection fraction may be reduced, but what matters the most here as the cause of the shock is that cardiac output is reduced, because a patient with an ejection fraction of 10 to 15% can be very hemodynamically stable. But if their cardiac output is significantly reduced, that's when you'll see shock states. Let's look more closely at regional LV dysfunction. This is defined as impaired contraction in a specific segment of myocardium. The causes for this are most commonly ischemia or myocardial infarction, or certain cardiomyopathies that present with these regional wall motion abnormalities. Clinical signs you may see outside of using TEE include EKG changes, whether it's the ST segment or T wave, arrhythmias, increased pulmonary artery pressures, or heart rate changes, whether you see new tachycardia or new bradycardia. And the treatment for these, especially if it's ischemic disease, going to the cath lab for potential revascularization, medications such as thrombolytics, antiplatelet or anticoagulant agents, and then optimizing supply versus demand when it comes to decreasing the heart rate, increasing the mean arterial pressure as well. Some of the views I'll use to assess regional LV dysfunction include the mid-esophageal four-chamber view, two-chamber view, long axis, and the transgastric short axis view. Keep in mind that the patient may have already had baseline abnormalities. You'll also want to see if it's consistent with one coronary artery distribution. The most important thing to look at is thickening of the left ventricle. It's more important than motion of the left ventricle, where normal thickening is defined by greater than 30%, hypokinesis 10 to 30%, and akinesis less than 10%. Take a look at the RV, because if that's dilated and failing, it may indicate a right coronary artery infarct that's causing the bradycardia and RV failure. You can see a hypokinetic anterior wall with that first echocardiographic clip. The next echo clip, you see a left circumflex artery injury where you have poor wall thickening of that inferolateral wall segment. And then these other echo clips at the bottom, you see akinesis, especially of that LV apical area, and you have thinned myocardium that's hardly thickening at all. And then you have poor function of that inferior wall in that last echo clip with a subsequent aneurysm that's present. The final cause of the shock state that we want to look at is afterload, where we have intracardiac and extracardiac causes of shock. What downstream non-LV factors are negatively influencing transport of blood to get to the organs? The first factor is looking at left ventricular outflow tract obstruction. This is defined as obstruction of blood flow either by the anterior mitral leaflet or other structure at the level of the LVOT. Obstructed blood flow and even mitral regurgitation from systolic anterior motion of the mitral valve reduces forward cardiac output. The causes are hypertrophic obstructive cardiomyopathy, where you have systolic anterior motion of the mitral valve, or the presence of something more congenital or acquired, where you have a subaortic membrane. The clinical signs are hard to differentiate without echocardiography, but it may be a picture where you see worsening clinical status in a patient who has been given inotropes, because the treatment for this is where we slow down the heart rate, increase intravascular volume, decrease inotropes, and increase the mean arterial pressure. The views I'll be looking at are the mid-esophageal long axis view. When I look at the mitral valve, I want to assess, is that anterior mitral leaflet entering the LVOT in systole? Also, is there the presence of an MR jet as well? And we call this the Y sign because there's turbulent flow back with that MR jet and also out the LVOT. And when you see LVOT turbulent flow, we'll want to assess to see if there's a high gradient. And also it will clue you in if you see a dagger-shaped waveform when you perform continuous wave Doppler. Lastly, let's look at the LV interventricular septum to see if there's very significant thickening present, which could predispose a patient to SAM. The next cause of abnormal afterload that can contribute to a negative clinical hemodynamic picture are problems with the aortic valve, whether it's aortic stenosis or aortic regurgitation. And I know aortic regurgitation is not a cause of high afterload, but because the aortic valve is downstream from the left ventricle, I kept it in this category just so we can think of aortic valve factors here. Aortic stenosis causes obstruction that impedes forward flow, or for aortic insufficiency, there's regurgitant flow that reduces forward flow to organs. Some of the causes for this for aortic stenosis are when a patient has a calcific, bicuspid, or rheumatic valve, or for aortic insufficiency, the same as those previously listed, or aortic root dilation, endocarditis, or aortic dissection. You may hear a murmur using a stethoscope, and for aortic stenosis, you can see a narrow pulse pressure, whereas for aortic insufficiency, you may see a wide pulse pressure. There's many broad treatment options for these, but for aortic stenosis, you may perform a temporizing balloon, a replacement with a TAVR, a surgical aortic valve, or mechanical circulatory support. For aortic insufficiency, treatment with optimizing hemodynamics with a higher heart rate or vasodilators can be important. And also, this is one of the key contraindications to many types of mechanical circulatory support. So it can dramatically limit your options in settings of acute AI. To evaluate the aortic valve, the views we will use are the mid-esophageal aortic valve short axis and the mid-esophageal aortic valve long axis. Looking at the deep transgastric long axis as well to be able to assess the valve further and evaluate gradients. Some of the features you may see with echocardiography for aortic stenosis are a thickened hypertrophic left ventricle because you have that high afterload you're squeezing against every time. Also, looking at the leaflets, is there poor leaflet opening? Is there turbulent flow in the aorta that's caused by that poor leaflet opening? And is there a high gradient present through the valve? For aortic insufficiency, you may see a dilated left ventricle if it's chronic AI. If there's poor leaflet quality or coaptation or a significant regurgitant jet that could be causing the aortic insufficiency. And lastly, looking at the aorta to see if there's possible dilation or dissection. The last intracardiac cause of high afterload is an aortic dissection. This is defined as a tear in the aortic intima that creates a false lumen in the aorta. You have decreased forward flow to your organs because of either true lumen compression, significant aortic insufficiency, or subsequent cardiac tamponade, which are complications of an aortic dissection. You also could have obstructed branch vessels and coronary occlusion. The causes for this are severe hypertension, connective tissue disorders, bicuspid aortic valve, or even trauma that can occur post-cardiopulmonary bypass in the cath lab or traumatic deceleration injury. Clinical signs you may see outside of echocardiography include blood pressure differential in the limbs, signs of complications, as we mentioned, such as AI, coronary ischemia, or tamponade, or organ injury, where you have decreasing urine output, rising lactate, altered mentation. And the treatment for this type of aortic dissection, where you have a type A dissection, is surgery and having strict heart rate and blood pressure control as well. To evaluate for aortic dissection, you're going to use mid-esophageal aortic valve short axis and long axis views, mid-esophageal ascending aorta short axis and long axis views, and then your descending aorta short axis and long axis views. When looking in the aorta, look for the presence of a dissection flap. You may also see entry tears in between the false and true lumens as well. Evaluate for complications of an aortic dissection at this time. For the aortic valve, look for regurgitation and leaflet function. For the left ventricle, see if it's dilated, such as would be in the presence of chronic AI, or for the presence of regional wall motion abnormalities, which would clue you into the presence of coronary occlusion. Finally, rule in or out the presence of pericardial and pleural effusions. Again, this is a rare perioperative finding, but it could be more common in patients with associated trauma. The last diagnosis in this afterload category is the possibility of this extracardiac cause of distributive shock. This is defined as severe peripheral vasodilation. Decreased SVR leads to decreased mean arterial pressure, and low mean arterial pressure causes organ ischemia. Significant vasodilation also causes blood to pool in the periphery and not necessarily be sent to organs. Initially, you can have relative hypovolemia, which causes a decreased preload to the heart. The causes of distributive shock are frequently anaphylaxis, sepsis, neurogenic shock, or anesthesia vasodilation. Specific to anaphylaxis, you may see bronchospasm or the presence of a rash. For sepsis, you may see a fever or an infectious source. For neurogenic shock patients, you may have one who has spinal cord trauma or a recent spinal anesthetic. And then as it relates to anesthesia as a cause, the presence of recent vasodilating agents. The treatment here, of course, are pressors, fluids, and then treating the underlying cause. What are some of the ways with echo that we can identify distributive shock? Well, you can look with your views at the mid-esophageal forechamber and transgastric short axis views. Some of the features you may see are that your left ventricle is hyperdynamic with a normal left ventricular end diastolic diameter, and that your RV size is frequently normal as long as you've been resuscitated and not underfilled as it would be in a patient with hypovolemia. The cardiac output, if it's calculated, should be normal or high here. When there's significant decrease in SVR, the patient compensates with an increased cardiac output. Some of these patients may have less markers of volume responsiveness after their initial volume resuscitation as well. This can be one of the most clinically relevant slides here, is how to actually differentiate hypovolemia from distributive shock. We already mentioned the left ventricular end diastolic diameter being less than 3.5 centimeters and underfilled if there's a deficit in preload, but being normal in patients with low afterload. The RV is underfilled in patients with low preload because there's less volume in the body, whereas patients with low afterload can have normal RV size. Some of the indicators of volume responsiveness that might make us think more highly of low preload being the culprit of the shock state is LVOT VTI variability greater than 12 to 15% and SVC collapsibility greater than 36%. And then cardiac output is low in patients with low preload, and it's normal to high in patients with low afterload. If you have not done this already, please reach out to us to get your copy of the T-Time Rescue TEE protocol. Either leave a review or hit the like button. Write us a comment sharing what you like and leave your email on that, and we'll send you this document. Again, you can use it electronically, you can print it out and use it however you find it useful to you. By this point, we've gone over both part 1, where we introduced the T-Time Rescue TEE protocol, and part 2 of Rescue TEE, Common Diagnoses and Shock States. Stay with us. We're about to finish with a part 3, where we have cardiac arrest considerations, clinical application outcomes, limitations, and logistics. This is going to be episode 17, Rescue TEE, everything you need to know, part 3. Thank you guys again for watching. Feel free to hit that subscribe button if you want content to be brought right to you as we make it. Also, leave us a comment. We love to hear what you think about this content, and if you do anything different in your practice so that we can all learn from each other. But thank you again for watching. We'll see y'all next time.